Mental health can be a very broad subject, so today we're going to narrow in and focus on cognition. We've invited Dr. Joel Mack to join us and educate us on the cognitive issues associated with Parkinson's and the impact it has on our lives. Dr. Joel Mack, a neuropsychiatrist at the Northwest Parkinson's Disease Research, Education, and Clinical Centers at the Portland VA Medical Center. He has been practicing psychiatry for more than 15 years and has published articles on cognitive impairment and Parkinson's disease. Dr. Mack, thank you for taking the time to join us today. I want to welcome you. And at this point, you're the expert, so I'm going to hand it over.
All right, sounds good. Hi, everyone. Thanks for joining. Thanks, Amy, and thanks, Brian Grant, for having me. And thank you for the intro. As stated, I'm a psychiatrist who works in the world of Parkinson's disease and have through most of my career. And I'll that will become evident why as I'm going through some of my slides, which I'm going to take a second to share. All right, are those coming through? Okay, see the slides? Good, okay. All right, and as stated, I'm going to sort of hone in on cognitive issues in Parkinson's disease. I don't have any conflicts of interest to disclose. In terms of talking about cognitive issues, so my goal is to kind of answer these questions I have here. So just to start with, what are cognitive issues and how do they look in Parkinson's disease specifically? Who might be at most risk for developing cognitive symptoms, and are there things we can do to prevent them? And in the case that someone is experiencing cognitive impairment or cognitive symptoms, how can we address them? And I'll kind of go through the gamut of medications and various lifestyle and mind-body interventions and talk a little bit about what might be to come. Another important aspect, I think, that I'll spend some time on is how do other symptoms of Parkinson's disease or the treatments that we use affect cognition, or how might they play into the picture? And then talk a little bit about just some resources or next steps. And then I think at the end, we will cover some questions. So Parkinson's disease historically was described as a movement disorder, which it is. People experience tremor and slowed movements and gait changes, things of that sort. But over the years, we've also noted the presence and importance of what we call non-motor symptoms. So non-motor symptoms run the gamut from autonomic nervous system changes, things like constipation, swallowing trouble, blood pressure changes, to sleep disorders, so excessive sleepiness, behaviors that might occur at night, as well as some other sensory issues, pain, fatigue, things like that. But as a psychiatrist, I entered this world looking at or interested in the neuropsychiatric aspects of Parkinson's disease, which we now know can be just as important and sometimes troubling as some of the motor and movement symptoms. So neuropsychiatric problems that it can run the whole gamut from depression and anxiety to psychosis, which is hallucinations and delusions, things like impulse control disorders, so impulsive and compulsive behaviors, and then cognitive changes. And as we said, today I'll focus on the cognitive changes, but I will touch on some of the other symptoms as well. So this slide is just displaying what one might call a sort of typical progression of symptoms in Parkinson's disease. However, as we know, and we all probably know, that it can be a very individual illness as well in terms of when it affects you, how it affects you, what mix of symptoms one has, how it progresses. But generally, some neuropsychiatric symptoms like anxiety and depression may actually be some of the earliest symptoms of Parkinson's disease, even before diagnosis or before motor symptoms. And then cognitive impairment in various forms that I'll talk about, often in milder, what we call mild cognitive impairment forms, may be present early on in the disease course. And then dementia, often thought to come later, and I'll talk about that as well. But so MCI and dementia are underlined there. I will talk about those in significant detail. So just to start to think about why people with Parkinson's might experience cognitive symptoms. So these are, I won't go into too much detail, but these are the corticostriatal palato-thalamocortical loops. The pink one on my left is the motor circuit. Those are the parts of the brain that play into the motor, how normal movement, and then where things can go awry in terms of Parkinson's and some of the movement symptoms. But in analogous sort of areas, the same parts of the brain, there are also what we call the associative or cognitive circuit, so the green one. So those pretty close to the same areas, just slightly different parts, are also involved in cognition, these same loops, these same circuits. And then on the right in purple is the limbic or emotional circuit. So we also know that there's emotional areas in these parts of the brain. So, so Parkinson's can affect across the board movement, thinking, emotions, and often these things all play into each other. So this is one of the busier slides, but I'll kind of tease it apart a little bit because it'll be a basis to go through the rest of the talk. So I'm going to talk a fair amount about what we call mild cognitive impairment and then dementia. So on the left of this, we have risk factors. What are risk factors for developing cognitive impairment over the course of having Parkinson's disease? So these can be demographic factors like male sex, older age of onset of Parkinson's symptoms. There can be genetic variations that affect the onset or whether or not someone has significant cognitive impairment or cognitive issues. Other comorbidities, so things like having high blood pressure, diabetes, or orthostatic hypotension, and then some Parkinson-specific factors like REM sleep behavior disorder, hallucinations can be associated with cognitive impairment, anosmia, or the loss of sense of smell is a risk factor. And then there's other lifestyle aspects, as I started to refer to comorbidities, but things like diet may play a role, tobacco use, caffeine use, alcohol use, and then potentially other exposures, traumatic injuries to the brain, pesticide exposure. Some of this is, has question marks because it's still being teased out, but this idea that there's a set of risk factors that if we could figure out ways to alter those, we might be able to alter the progression to having cognitive issues. So mild cognitive impairment, I'll call it MCI, is essentially it's a gradual cognitive decline. It's usually considered early cognitive decline, where people, if you get tested, do cognitive testing, might have some impairment, objective impairment on testing, but the impairment is not yet to the degree that it will affect your day-to-day functioning. So it's not affecting your ability to engage in the activities you like to engage in, or drive, or do chores around the house or things like that. Once it does get to the point where it progresses to affecting day-to-day functioning, that's when we term it dementia. So dementia is simply stating that there's cognitive impairment or difficulties with thinking and memory that start to affect functioning. Obviously, there's significant interest in where in this progression we might be able to intervene, and that's a lot of the ongoing work being done that I'll touch upon. But in terms of a lot of the numbers from over the years, those with Parkinson's reaching the stage of dementia, it was thought that about 50% would reach that stage at 10 years, and 80% or more over the full course of illness. With milder cognitive forms being about 25% of people early on, or even around the time of diagnosis. I'm gonna give some what I think is encouraging news that takes another look at some of that as we go on. So this is another form of the last slide that I showed you, but this is reflecting reality a little bit more, I think. It used to be thought there was just this straight progression, someone who went on to have mild cognitive impairment, then would advance 5 years later to have dementia or on some timeline, but that it was sort of a linear a linear process. But this is actually showing, so early on, and the red dotted line there is time of diagnosis. Some people will start out at that time, will have some form of mild cognitive impairment, not impinging on function, but some degree of impairment. There's also been an interest lately in SCD, the purple area, which is subjective cognitive decline. This is people who are saying, I just don't feel like I'm thinking as clearly, or I'm having memory trouble, but they do fine on testing and don't have any impairment. So it's just a subjective experience of having some cognitive issues. So from there, or from mild cognitive impairment, after diagnosis, there's sort of fluctuations back and forth in terms of degree of cognitive issues. So somebody might have some mild cognitive impairment on testing, and then as time progresses, they may segue back toward more normal cognition without having significant issues. Others will progress more rapidly to a dementia diagnosis, where others will have a slow progression over many years. There has been some recent research that people with Parkinson's who have subjective cognitive complaints, that aren't that their testing is still showing no issues, often will go on to have some functional impairment within the few years after their complaints. I do just want to set the stage a little bit for still this idea, just what are we talking about when we talk about cognitive issues or cognition or neurocognitive areas. So generally there's thought to be five main areas of cognition. This figure adds a sixth to it. But the five we usually talk about are attention or complex attention, executive function, perceptual or visuospatial function, language, and learning and memory. And this also adds social cognition, sort of engaging with those around you. In Parkinson's disease, we most commonly see, at least early on, the deficits that we see are in executive function. So that's things like planning or sequencing, or doing things in a stepwise manner, kind of multitasking, which would also involve complex attention to some degree, as well as visuospatial or perceptual issues. So kind of where one is in space and perception, construction, being able to construct something in 3 dimensions. So those are the areas most commonly affected early on in Parkinson's specifically. That's to differentiate it a little bit from, say, in the case of, say, Alzheimer's disease, where the early symptoms are in learning and memory, so being able to recall things, as well as language, so things like naming an object or coming up with the right word. So there's some differences early on. And that will be important as we engage in and develop interventions and treatments down the line. So these are some numbers that I'll go through. This is a very recent work from University of Pennsylvania, from Dan Weintraub, who's there, who's a very important person in this realm of Parkinson's disease work. But this hasn't been published yet, but this is some newer numbers looking at the risk of developing dementia in people with Parkinson's disease. So the older numbers, as I said, 50% at 10 years, 80% over the course of the illness. A lot of that was, different sample sizes of people, different approaches at how they were diagnosing dementia. So really wanting to get a bigger group and an idea of kind of relooking at the prevalence or progression. So the news here, I think, is that in this case, so on the left, you have the number of years with a Parkinson's disease diagnosis, and then the likelihood at each amount of time for progression to a dementia diagnosis. So just to look at year 10, which I previously said was a 50% likelihood, this group has found that it's 26.5% likelihood, so much lower. There's actually another big national sample that's also kind of doing the same thing. that found even lower rates. So the takeaway from this being, I think some good news that we don't think that the likelihood of progressing to dementia is as likely, or at least is not as soon as sometimes previously thought, that it might be further down the road. I also wanted to take the same information, and basically they split it up by age of Parkinson's diagnosis, age of person who was diagnosed with Parkinson's. So as I said, so older age and older age of Parkinson's onset or diagnosis are known to be risk factors for developing dementia over time. And again, I kind of look at year 10 because that's a common time that people utilize with these figures, and what the other numbers were that I gave you. But this shows that, so if someone was diagnosed with Parkinson's disease at a younger age, so less than 56 years old, their likelihood of developing or a dementia diagnosis 10 years in is about 4%, so much lower. If diagnosed between 56 and 69 years old, it's in about the low 25% range, and then the likelihood increases fairly significantly for those with a diagnosis after age 70 years old. So there's this is to highlight that we're finding there can be significant differences on some of these different demographic or lifestyle factors, or symptom factors in terms of the risk of developing dementia. And if anybody has questions about this, toward the end, we can talk more about it. I should touch upon the fact that this is also in terms of the idea of young onset Parkinson's disease, which is typically thought to be people diagnosed at age 50 or younger. It is thought, in line with kind of the left side of this table, that the progression through stages of cognitive impairment is much slower, and that they have less cognitive impairment overall until many years, 20, 25 years later in many cases. So we often talk about issues with cognition or cognitive impairment in terms of sort of the testing that we do to look at it, and how people are functioning on a day-to-day basis. But we know that in terms of quality of life, how cognitive issues in Parkinson's play out can have a lot of different factors or a lot of different realms that are important. So just in terms of some of the abbreviations, as I said, SCD is subjective cognitive decline, mild cognitive impairment for MCI. So those are how the cognitive issues themselves affect quality of life, as well as dementia. But then there's other aspects. So somebody's personality, it can play a significant role, or what other strengths or weaknesses they might have can kind of color how the cognitive impairment affects them very much. So it's not just a clear one-to-one, you have cognitive issues and you have these problems. There's a lot of other factors that play into it. Your total non-motor symptom burden. So I showed the figure of the range of non-motor symptoms. And so we know that the non-motor symptoms can play a significant role in how one is doing day to day. And so what mix or other symptoms people are experiencing can play a very important role, and also how those things are treated. Cognition and lifestyle. So depending if somebody's working or volunteering or their day-to-day activities in life, how cognition plays into that can be really important in terms of occupation, and the role one's occupation plays in life. And then, of course, with caregivers, spouses, family members, friends, kind of the environment around you interpersonally can have a significant effect on how any cognitive issues play out in a particular case. So what should we do if somebody is starting to have cognitive symptoms, or maybe has not had any yet, any cognitive issues yet, but just in terms of preparing. So these are I'm going to start with just some kind of general thoughts and recommendations, and then go through in more detail. I'll start by saying number one. So this is for sort of early to mid stage people with early to mid stage Parkinson's disease that maybe are not yet experiencing any significant cognitive issues or motor trouble that is affecting day-to-day function. So exercise is going to be, no matter where you look, exercise I think is going to be number one. So to keep your body moving, and I'll talk more about that. Staying active and engaged socially. Again, I'll talk more about this, but this is one that, coming out of pandemics and the state of the world, this isn't always the easiest thing to just find ways to engage socially for a lot of people. Engaging in cognitive training exercises, learning specific coping strategies. So getting involved with physical therapy, occupational therapy, figuring out ways to develop strategies early on to deal with whatever issues you might have related to Parkinson's disease. Nutrition, again, for I think all of us, but particularly in neurological disorders, nutrition does affect cognition, and so I'll talk a bit about diet, and then some just sort of, again, getting into cognitive strategies, trying not to multitask, given the issues one can have with executive function, and taking your time and communicating any issues you might be having with caregivers, your doctors, your providers. And then I'll talk about some things we might do later on, in later stages. So in terms of developing routines, this is when we start to talk more about certain, I think, medications coming into the picture that might help with cognitive impairment, advanced planning aspects, and then the importance of caregivers, care partners taking care of themselves as well, and taking care of their own mental health in order to be able to provide the best care. So exercise, as I said, this idea that exercise is medicine, I think this is fairly well distributed, this idea through the Parkinson's world these days, but it's definitely still, I think, the number one thing we can try to do. So this just gives some general ideas, but the goal of having 2.5 or more hours per week of exercise, these can be aerobic exercises, walking or treadmills or aerobics, strength training, or skill-based. So skill-based being things like, say, Tai Chi or dancing, or boxing. There's Rock City Boxing. There's programs out there. There's Parkinson-specific exercise programs. But the goal of keeping our bodies moving as best we can. And we know that exercise actually changes the brain in Parkinson's disease. So doing skilled exercise, skilled tasks, as well as aerobic exercise, can increase blood flow, can lead to neurogenesis, which is growth of neurons, basically, or connections of neurons, as well as help kind of those circuits that I described earlier be working optimally. And so improving that circuitry can improve movement or decrease movement symptoms, as well as cognition, specifically executive function is the kind of main thing that we found. Again, that's things like planning and sequencing and multitasking. It can also significantly help with mood and motivation. And all of these things, as I talked about, sort of play into each other. If someone's mood is improved, they might be more motivated to engage in activities, and it kind of forms a positive cycle. Diet. So there's this idea, there's been mixed results in Parkinson's, but overall, in terms of aging and preventing cognitive decline over time, there's generally the Mediterranean diet is what you hear a lot about. There's also, this is the MIND diet, which is the Mediterranean diet combined with a hypertension, high blood pressure prevention diet for delaying neurodegeneration in various illnesses. This is not just Parkinson's disease, but just kind of some general guidelines, eating fruits and vegetables, whole grains, fish and poultry as opposed to red meat, cutting out fried and processed foods or too many sweets, butter, margarine. And then there's some research, although it's mixed, and some of it's in animal models, that specifically caffeine and vitamin D may be helpful for people who, in some studies, for people who have used high amounts of caffeine, have more coffee, actually had less risk of Parkinson's disease or better function. And this hasn't panned out in all studies, but still things that we're looking at. And vitamin D is sort of a similar picture. This is just showing that the diet that I just mentioned, the MIND diet, slows cognitive decline with aging. So if we're looking at essentially which of those lines has the steepest decline, the darkest one, those are the ones with their diet was furthest away from this MIND diet, where the top sort of staggered line, the slightest slope there, those are people who had a high score in terms of their diet reflecting this MIND diet. So their progression in terms of cognition, in terms of any impairment in cognition, was slowed significantly over time. So I mentioned this idea of avoiding social isolation, staying socially active, engaging with other people, which again, I know sometimes we as doctors or providers kind of say, well, this is what you should be doing, and then not always have exactly the answer of how to do it. I mean, I know sometimes it's easier said than done, but we'll talk a bit more about that and some resources. But this idea that social isolation or loneliness can have effects in the body and in the brain over time. So they can activate what's called the HPA axis, which is the hormonal axis in your brain and throughout your body, which can increase cortisol, which is considered the stress hormone. So essentially increase stress, which can impair immunity, can cause insulin resistance, and ultimately cause more or increase symptoms, especially non-motor symptoms, so things like disrupted sleep, depression, anxiety, potentially cognitive issues, as well as potentially worsening motor symptoms, which obviously having more symptoms can lead to less interest in social connection or getting out to do things, and one can get kind of in this cycle. So in terms of this idea of prescribing social engagement, this can mean anything from, as I've written some examples, coffee with a friend, engaging in a church or faith community, volunteering, joining a club, taking a class, playing cards, attending support groups, peer support, or even now there's a lot of kind of online resources just to connect with other people. Along those lines, starting to think of ways to sort of combine maybe being social with exercise, which, as we stated, we know has positive benefits. There's been a myriad of study of what I'm calling mind-body intervention. So things like mindfulness, Tai Chi, dance, yoga, exercise and PT physical therapy programs, acupuncture. And these mind-body activities both can be social and can be fun. So I think one example I hear from a lot of people is something like Rocksteady Boxing, the boxing program for people with Parkinson's, that there's the physical aspects of doing it, but people also describe that they have a lot of fun and they get to talk to other people while they're there and enjoy it. So I'll touch on some of these specifically, including mindfulness, but so in terms of cognition, exercise, as well as dance, so sort of skilled exercise or learning a new skill, can have benefits, especially for subsets of cognition like executive function. And all of these things have potential to help with quality of life, mood, decrease anxiety, potentially sleep. And there's a fair amount of resources out there for these types of programs or activities. I do want to talk a little bit about medications specifically, although I think in some ways, I think the non-pharmacological aspects are as important or more. But to start with, as opposed to adding a medication or treating with a medication for cognitive issues in Parkinson's disease, one of the first things I often end up doing as a geriatric psychiatrist working with people with Parkinson's is taking away medications or seeing if we can simplify medications. There's a number of them on here, but I think some of the biggest culprits that I come across that we work to see if we can decrease or stop are things like antihistamine. So this is like diphenhydramine, which is also Benadryl, the brand name, or hydroxyzine. And these can be in a lot of like over-the-counter sleep aids that people might end up taking, or over-the-counter medications. These can significantly affect cognition, thinking and memory, and cause sort of a clouded thinking if somebody's using them regularly. Another medication class are benzodiazepines. So these are things like lorazepam, clonazepam, alprazolam. Now, we also do use these medications not infrequently in Parkinson's for things like REM sleep behavior disorder. So if somebody is reenacting dreams while in their sleep, we might use some at night. And sometimes they are used for anxiety, but generally we try to avoid them if they're not really necessary because of their cognitive side effects. And then some Parkinson's medications themselves, which have these anticholinergic effects, kind of like diphenhydramine, can be problematic, although it's always about working with your doctors to weigh the risks and benefits with medications like these. And then opioid pain medications can clearly have cognitive effects as well, sort of cognitive clouding or slowing or memory issues, attentional issues. And so obviously limiting those unless they're completely necessary. So what about medications to intervene or to treat cognitive issues in Parkinson's disease? I'll start by saying that as I said earlier, this progression from having no cognitive issues whatsoever through to dementia over the number of years, ideally we would be able to start intervening earlier on before people develop these issues, or in the early stages of developing these issues, in hopes of changing the illness course, or changing the brain in a way that they wouldn't continue to become more severe. We don't have anything yet, except I would throw out, maybe I would say exercise, but we don't have any interventions that have been proven to change disease course at this point. But we do have some that might help symptomatically as time goes on. So there's been a number of trials to see if medications are helpful at the mild cognitive impairment stage, including cholinesterase inhibitors, which I'll talk about, rasagiline, which is a Parkinson's medication, transcranial direct current stimulation, and I'll talk about this more in terms of future directions, which is a neurostimulation or neuromodulation with electricity to try to help with cognition, as well as cognitive rehabilitation or cognitive training programs. None have clearly panned out in terms of intervening early at the mild cognitive impairment stage. In terms of FDA-approved medications and ones that have clearly shown benefit at the dementia stage, in terms of randomized controlled trials, sort of the gold standard of assessing medication, rivastigmine is still at this point the only medication, which is a cholinesterase inhibitor. Others are sometimes used because they have been shown to have some benefits, but in a randomized controlled trial across the board, rivastigmine is the main one that so far that we've used. So this is just kind of laying out some of the main memory and cognition medications that have been tested. A number of these were developed mainly in Alzheimer's disease, but then found to be, in the case of rivastigmine, very helpful in Parkinson's disease as well. And so just giving some dosages. So common side effects of rivastigmine: nausea or belly upset. In the pill form, it can sometimes worsen tremor, but there are patch forms as well, which can decrease side effects. So a patch that you wear as opposed to an oral formulation. I think time-wise, I'm gonna start cruising through a couple things. But the other thing is, how do symptoms of Parkinson's and the medications we use to treat Parkinson's affect cognition? So with levodopa, there's, over time, people might develop what we what we call on and off symptoms. So when your medication's working and it's on, feeling more relaxed, feeling like thinking is clearer or faster, feeling more self-confident, things like that. Where when people suffer from off periods, which might affect motor and non-motor function. So motor issues might be being more rigid or freezing of gait. And then non-motor issues might be slowed thinking or feeling more sort of dysphoric or irritated or even having panic attacks, lower self-confidence, and kind of those things affecting cognition. So the ups and downs of Parkinson's medications themselves can significantly affect how one is feeling in terms of these non-motor realms like thinking and mood. And this is just looking at, so this is looking at different symptoms when someone is when their medications are working well versus off medication states. And so the blue lines are the off state, and you can see things like anxiety, depression, concentration and attention, which is part of cognition. All of these can be significantly worse or having significantly more symptoms in the off state. We also know that mood can significantly affect thinking and memory and cognition, and there's a lot of overlap between Parkinson's symptoms of Parkinson's, depression symptoms, and cognitive symptoms. All three of them, depression can affect concentration, can cause decreased memory, impaired problem solving, as can Parkinson's disease itself. So having someone help tease out, what might be related to depression and treatable in terms of mood can be really useful for also addressing cognition. The other big thing that I will say briefly while I'm here, before I forget about it, is sleep apnea. Untreated sleep apnea is one of the top things I would say I see in terms of causing cognitive issues throughout the day for people who have sleep apnea diagnosed but aren't using their CPAP or treating it. Can definitely affect cognition or make matters worse. Anxiety as well. I won't go into too much detail here, but prominent anxiety can significantly affect cognition and thinking, and also is treatable. So anxiety is one of these things we often see in those non-motor off states, and so people might start to have anxiety. I'll go to this slide, a busy slide, but if you look along the bottom, so people can start to have anxiety around things like fear of falling, if their gait is freezing, about cognitive impairment itself, around getting lightheaded or blood pressure dropping. And so this is where bringing in other people such as PTOT or treatment of mood and anxiety can be helpful in actually addressing cognition as well. Mindfulness is, I think, if you look around, mindfulness is kind of all over the place these days in a positive way. So mindfulness is this idea of engaging in a practice, a day-to-day practice of paying attention to the present moment, sort of non-judgmentally, just being in the present moment. And we know that what our mind is doing affects how our body is working and vice versa. And so using a practice or becoming skilled in mindfulness can have a myriad of benefits across many disease states. It's been studied in many areas, but in Parkinson's as well. And there's Parkinson's specific mindfulness-based therapy classes and groups out there. And it will be in our resources. There is actually one mindfulness-based stress reduction course through Brian Grant as well. So in terms of where to find these things. But mindfulness practices, which is a bit different than relaxation, but which I won't go into, relaxation can also be very useful, relaxation exercises. But this is a survey of people with Parkinson's who engaged in a mindfulness practice, over 1,000 patients, and what they thought it helped with versus not. And across the board, they thought it helped alleviate their symptoms, whether it was their slowed movement or tremor or gait problems, or their sleep issues or mood or depression. So mindfulness reported a myriad of benefits from engaging in mindfulness. For the sake of time, I won't go into too much detail here, but I wanted to mention that psychosis, so this is having hallucinations, which are sensory experiences or sensory perceptions without there being an actual stimulus, or delusions, or some milder forms of these symptoms, is highly associated with cognitive issues, and as cognitive issues increase, and so psychosis symptoms can become problematic, and sort of increase caregiver burden, nursing home placement, and it's something I do a lot of work with. The reason I brought them up is because they can be highly associated with later stages of cognitive impairment, but also that there's been some findings showing that pimavanserin, which is one of the main or the only FDA-approved treatment for psychosis and Parkinson's disease, has actually been shown to work better or have a more robust effect, which is the middle graph there, basically just showing it had a more robust effect when there is cognitive impairment present, but also when someone is using something like ribostigmine, one of the other cognitive medications that I mentioned. So just to kind of put some highlights of research out there, that we're finding that using some of the medications for cognition may actually help some of the other medications we use to treat things like psychosis. So again, treating mood, treating anxiety, treating psychosis can help with the whole picture. In terms of what's on the horizon, I'm surely not going to go through all of these, but this is investigational drugs for addressing cognitive issues in Parkinson's disease. Many trials going on, some of which are completed, some of which did not. So atomoxetine is one there was some hope for that did not pan out, but many ongoing trials. So I'm hoping to come back and update you down the line with some positive news on some of these. And the other aspect that there's a lot of work being done in is neuromodulation. So most people, or many people with Parkinson's disease, are familiar with deep brain stimulation, which is one form of neuromodulation. It's what we call an invasive form because there's actually going into the brain with electrodes to treat things like dyskinesias or motor off symptoms. But there's also a number of other forms that are non-invasive, so things like transcranial magnetic stimulation, transcranial direct stimulation, or focused ultrasound, which there's a lot of work being done with some promising results. So these are very complex circuits playing into cognition, and so there's some studies have shown positive outcomes, often just for the brief time after doing something like TMS, transcranial magnetic stimulation. But there's continued work to try to dial these treatments in. And the other piece that is on the forefront is doing a lot of combined treatment trials. So things like doing exercise with neuromodulation, or cognitive training with neuromodulation, or cognitive training with exercise, and sort of combining to fine tune and get the best of all worlds to help slow progression of these issues. And cognitive training is the other aspect I mentioned. So cognitive training being essentially the idea that with practice, one can strengthen their cognition, just as if they were lifting weights for physical strengthening. This is often done by computer-based programs. There's been, again, some mixed results, but some promising results in terms of improvements in working memory and executive function, which are some of the main issues for people with Parkinson's disease. Has the benefit of safety, so different than putting a medication in your body, which I think is always useful. As I said, combined trials, and there's groups out there to help with day-to-day cognitive strategies more generally as well. So developing routines, using checklists, allowing extra time, how to time your medications before outings or activities. And so, I think ultimately it's going to be some mix of all of these things being beneficial, and we're continuing to tease that out. So I think that should be right about time. This is just a kind of mindfulness quote that I throw in at the end. So you can't stop the waves, but you can learn to surf. So, we can't always change the things that are coming down the road, but we can kind of figure out ways to navigate them and to manage them. And then I think I will include my slides for people to have access to, and there's a number of resources across various areas that I touched on during the talk. So thank you.
Thank you very much, Dr. Mack. That was very enlightening, and I appreciate you personally talking about the young onset, because that is something that has been weighing on my mind. We did have a couple questions come in, and if anybody out there has any questions, feel free to put them in the chat box and we'll try to get to them. We just discussed DBS. So you're saying that there has been shown to be an improvement in cognition with DBS. Is that a slowing of progression, or is that almost a reversal?
So I should have, again, at the expense of digging in a lot of depth, I covered a lot of ground. So DBS has had some mixed results, deep brain stimulation, so which is usually done, as I said, for motor aspects of Parkinson's. There's been mixed results here, but DBS has actually been shown in some cases, although rarely and perhaps subtly, to cause increased issues with executive function. So when done for something like, say, dyskinesia. So there, in some cases, people might have more cognitive difficulties after DBS. However, that's using DBS specifically for in the movement areas of the brain. They use DBS other places as well, not necessarily in Parkinson's, but some of the research is using it in the cognitive circuits of the brain. And so figuring out if we can also use it in cognitive areas of the brain to improve cognition, as opposed to how we're typically doing it now in Parkinson's to address motor symptoms.
Sorry, live talking with the dog and trying to mute myself. Something that we talked about diet, and we all know, we have heard Mediterranean and the mind diet being very good, but what about a vegetarian diet? Is there any results from that? I know it's very similar to the mind and Mediterranean, but somebody asked specifically about vegetarian.
I will be honest in that in what I know of the literature, I don't know that I've come across specifically in terms of for people with Parkinson's, a vegetarian diet. There very well may be something out there, but I have not come across it. As you stated, I think, although it is not the same, the Mediterranean diet is sort of approaching vegetarian in terms of small amount of protein, in terms of fish and things like that. I think what I would say generally about the vegetarian diet is that would be a main concern is making sure you're getting the protein that you need as well from the diet that you have, because that's going to be important for maintaining muscle mass and things like that in Parkinson's disease. But I can circle back. I don't know of any specific studies looking at vegetarian diet in Parkinson's disease.
We had a fitness instructor write in asking about dual activities during their workouts with people with Parkinson's. Is that something that would be useful, and should they develop a program that involves more of these dual tasks?
I think that's kind of what I was getting at in terms of the future directions, the idea of sort of cognitive training also being part of exercise, which is, as I said, so for tasks which in some ways can be dual task-ish, with things like dancing, where you're learning skill-oriented aspects and kind of dual tasking to learn a new skill. These can be significantly beneficial for cognition. They've been shown to be. So yeah, I think continuing to look at the studies and what specific aspects of, say, exercise or dual tasking or cognitive training are most useful to tailor these things. But yeah, I absolutely think given dual tasking is sort of it's a mainstay of executive function. So anything that encourages continued executive function versus executive dysfunction over time, I think is useful to engage in.
Do you have maybe like a certain amount of time that should be included in the workout? I mean, I just know that sometimes it gets exhausting and very challenging, having gone through it myself. So is it something like out of the 30-minute workout you do a day, half of it should be a kind of this cognitive challenge component? Is there evidence on how much should be included?
I'm not sure if there's hard and fast evidence in terms of amount of time out of the 2.5+ hours a week of exercise. It may be out there. I would say, obviously, like I was saying, with some aspects of this, that it's included in something like dance or something like that, and maybe for a longer period. I would say, just generally, not to push it beyond tiredness or frustration. If you hit that point, even with encouragement, that would be a good time to stop. But I don't have an exact timeline in terms of the dual task training. I'd be interested to learn more about it, though, if people have resources.
Okay. Is there an interaction between opioids and, the interaction between opioids and cognition, is that temporary or permanent?
What I was mainly referring to are the temporary, when you're on the medication effects. So in terms of cognitive slowing and tiredness, and in the moment, with the idea of tapering off of them or stopping them. There has been some work on benzodiazepines, and I don't know all of it on opioids, but that people who are on some of these medications very long term, actually, it does increase the risk of cognitive decline or cognitive impairment down the line, especially with benzodiazepines. So there may be some long-term aspects, but I was mainly looking at the list as a means of, when I see somebody thinking about what can we pare back, what can we simplify, what can we get somebody off that could be affecting their cognition if they're not necessarily getting all the benefit that we want. So more the in the moment effects of those medications.
When I was at the World Parkinson's Congress in Barcelona, I attended a talk where they were comparing comparing apathy and cognition, and saying that apathy could be a precursor to the cognition. Do you see this as being because you're pulling back, you're not as engaged, or is it the chick or the egg? The apathy leads to the cognition, or the cognition leads to the apathy?
It's I think it's all of the above in some ways, which I'll tease out. And I was going to put a slide about apathy in there, but I just thought time-wise, there's so much to cover. So apathy is this aspect of losing drive or losing pleasure in engaging in activities, having more and more difficulty in initiating or kind of getting started with activities. And in some cases, just the complete loss of motivation to engage in the world around you. The way that I kind of think about apathy and because it can affect the approach, is apathy can have an emotional component, sometimes overlapping with depression, sort of not getting joy out of things, stuff like that. It can have a motor component, just kind of in terms of intertwining with slowed movements and things like that. So the actual ability to kind of get oneself going physically. And then there's a cognitive component, I think, where slowed thinking, or just the ability to kind of get one's brain moving in a way that they're able to initiate an activity or be motivated. So I kind of think about it across those lines. Apathy is associated significantly with cognitive decline or cognitive impairment. And I think in the later stages of cognitive impairment, you often see a lot of apathy. But I guess there's a lot of overlap, is what I'd say, but it doesn't mean that they're completely one and the same thing. There might be things that one could do if there's, although apathy is different from depression, there might be medications or engaging activities one could do to help address apathy over time, which doesn't necessarily mean that they're having a lot of cognitive impairment in that case. So a lot of overlap, and there's a relationship, but they're not completely the same thing, I would say.
Okay. And you mentioned doing cognitive testing, computer programs. Are there computer programs that are available to the general audience that they could do daily? Would that also include things like crossword puzzles or, jigsaw puzzles? How on a daily routine can we kind of challenge our cognition?
Yeah, I think a number of the things that were covered a little bit. So engaging in activities that almost are naturally dual tasking, like we said, things like maybe learning a new skill, taking a new class that you learned you're doing ceramics or woodworking or things like that. I do think there's, although there's not as much research behind it as physical exercise, I do think just keeping your brain busy with, reading, doing crossword puzzles, anything to kind of keep it sharp day to day. Socializing, engaging in conversation or expressing your thoughts. I think all of those things are useful. The cognitive training aspects, and I don't have a lot of personal experience with them in day-to-day clinical work, but are often computerized programs, or even now things like they're getting to things like virtual reality, where you kind of are doing a task over and over again. I'm not sure. I think one thing I think I had in my slide to be aware of, there's a lot of things out there that will tout, that they have these benefits, but maybe are not the right, it's being sold something or something like that. So I'm not totally sure in terms of what's available for Parkinson's specifically to the general public outside of kind of what is used in clinical centers. Again, it's areas that as I give these talks, I learn from people, and will look to update my own database.
Well, I think we have come to the end. I'd like to thank you very much. I mean, we just started getting comment after comment that this was a great topic, a wonderful speaker. So I thank you for joining us. I hope everybody learned something new today, and we are just reinforcing that exercise and eating right is what we all need to do. So get out there, socialize, get a walk in, and then go have something healthy with some fruit and nuts to eat.
Right.
Dr. Mack, again, thank you so much for taking the time to join us. And everyone else, I just want to thank you for taking the time out of your busy day, and that you're walking away with something that you can challenge yourself cognitively today. And I'm also going to borrow a phrase from Fraser, and I'm going to wish you all good mental health. So everybody have a great day, and thank you.
Thank you all. Take care.